So it's great that you know that the blood pressure is low. But why? Because the bleeding patient than the septic patient. Do you understand that? So it's important to have all of these numbers to help us sort of understand what's going on with the patient. Later in the semester, and I used to teach this content, and Jill's teaching it now, is shock. So I'm giving you the foundation. You got to get it now, because when she talks about shock, you're going to know why all these numbers are off. I can look at these hemodynamic parameters, and I could say he's septic shock, or he's hypovolemic shock, or he's cardiogenic shock, based on the numbers. Do you guys see that? So I'm going to give you a foundation. I uploaded this. I don't know if you guys printed this. I updated it and uploaded it. And I don't even know who did this years ago, but I stole it and tweaked it a little bit. But it's a really nice, quick table of all the things that we're going to talk about today. Okay. So students will ask me, do I need to know the numbers? What do you think my answer is to that?
Absolutely.
There you go. And you got to know what the concepts are, because if you come to clinical and you say, hey, Lorraine, so the CBC is 40. You should be having a seizure like me right now about that 40, because 40 is not normal. 2 to 5 for a CBC is normal. So you've got to be able to react to what those numbers are. Okay. Oh, tell me my clicker's not working now. So we are going to go nice and easy. Hemodynamics. Very general term. Forces involve the flow of blood. Okay. And we're going to take a look at volume. We're going to look at pressure, and we're going to look at contractility. Okay. So we're going to take a look at that. You've already done the non-invasive. You've done blood pressure. Simple, right? You've done blood pressure. But now we're gonna put that on steroids and do more. So we're gonna do arterial lines and central lines and some other kind of pressures. So we can be as simple as non-invasive getting a blood pressure. You all know, you go to your nurse and go, oh my God, their blood pressure is 70/40, right? Oh my God, we got to do something about that. So we're gonna take it to minimally invasive, and I'll show you that. Something called an icon, you might see. Okay. And then we're going to go to the really invasive, which is that Swan-Ganz catheter, or pulmonary artery catheter. Swan-Ganz are the two physicians who made up the catheter, but it's a catheter that's directly in the heart. So we'll talk about that. And we don't see the swans as much because it's quite invasive, lots of complications, but we need to understand the pressures, because when we do the non-invasive, you'll understand what an SVRI is. You have no idea what I just said. So you'll understand that. So I've got to teach you the swan, even though you might not see it that much. Everybody got that? There's a purpose to why I'm teaching you the swan. Now, I gave you guys, and I'm sure you looked at this. My son looked at this and goes, what the hell? There's a story behind this. Did you print this? Okay, because you're going to write on it. This was drawn by a cardiac nurse that I work with since retired. Very near and dear to me, so I use it when I teach them. If you don't like it, make your own version. But we're going to use it. And then at the end of today, you'll see my completed one on Canvas. It's just not the loose bit with all the questions in. So we're going to have things in the right atrium. We're going to have things in the left atrium. We're going to have things in the right ventricle. We're going to have things in the left ventricle. When you are studying hemodynamics, think of there's a left side of the heart and there's a right side of the heart. Everybody got that? So we're going to have left-sided pressures, right-sided pressures. That makes sense, right? Unless you don't have two sides of the heart, and you're probably not alive. Okay, so keep this out. So, preload. First thing that I asked you, I think. I can't find my balloon. Preload is volume. Preload is volume in the ventricle. So we have to have the right amount of volume, right? You all said dehydration, maybe fluid overload. So let's say we have the appropriate amount of volume. Nice contraction, right? Everybody got that? Nice contraction. Now, just going to tell me using all these things. Let's say we're volume depleted. Let's say we're hemorrhaging, we're trauma, or we're severely dehydrated. Not as much, huh? Now, let's say I'm in heart failure. What could potentially happen? It could burst if I do a balloon, but hopefully your ventricles don't burst. But what gets released when the ventricles are stretched so hard? And does it contract as good? No. So we've got to be in that ideal preload situation. We can have the ideal amount of fluid. Everybody got that? Too low a fluid, too high a fluid back. You want to be in that sweet spot. And I used the balloon. That's not like I saw somebody present. I really liked it because it made sense to me. You know, if I have a little bit of air in there, not really much of a contraction, right? So we've got to have the appropriate amount of volume. So if I ever say to you, what's the preload? You say, well, I got to think about volume steps. Make that connection. Everybody got that? When I talk about afterload, I talk about the resistance in the vessels. So I dropped my straw. Is it on the chair? Oh, excellent. So if I talk about afterload, it's the resistance that the ventricles have to push against to get the blood out of the heart. Everybody got that? Now I have a right ventricle and a left ventricle, so I have pressures on both sides. So when we talk about afterload, we're talking about resistance. Our vessels should have normal tone. Just think a straw, normal tone. Okay? When we are clamped down, my blood pressure is 300 over 160. Very small diameter and a lot of resistance. So coffee stir, a lot of resistance, right? To blow through and get the volume through that, it's hard, isn't it? Small. So high resistance, high afterload. Somebody who's septic, who has no tone in their vessels, low afterload. Everything but the kitchen sink can go through this. Do you guys see that? So that's why I use these. Normal is the straw. High afterload, coffee stir, lots of resistance in that vessel. Low afterload, toilet paper roll. Can you visualize that now? So what do you anticipate this low afterload patient's blood pressure being?
Like there's pain.
Yep. Right? There's no tone. So the pressure is 60 over 40. 300 over 160. High blood pressure. Do you guys see that? Now the SVR, which we're going to talk about, has to do with the afterload coming out of the left ventricle. So we would kind of tie that back to blood pressure. The PVR is in my pulmonary. I can have high resistance in my pulmonary system too, can't I? COPD, lots of resistance. Make sense? Okay, contractility, what it says. So when we think of, and when she talks about shocks, she's going to talk about pump, pipes, and pool. So the swimming pool is the preload. If your swimming pool is empty, are you going to jump in it? I hope not. If your swimming pool is overloaded, is the water going to spill out of the pool because you have too much volume? So preload, I always think of pool, swimming pool. Afterload, I think of pipes. What do my pipes look like? Do I have calcium in my pipes and I can't get stuff through? And then contractility is, how well is that pump? How well is my heart contracted? So I can have a problem with my pool, my pipe, or my pump. That makes sense. Pool, pipe, pumps. Okay, so those are three concepts. I'm going to show you how we measure those in a minute. These are concepts. We're going to take them into something that we can actually measure in a minute. But I need you to just pause on that and think about those things. Stroke volume is every time I contract out of my ejecting arm. Everybody got that? And if you look at this beautiful little table that I have, 60 to 70 milliliters every beat. So every beat, 60 to 70. That's all that the heart's pumping out. is 60 to 70 milliliters. That's the stroke volume. Now, if anything, preload, afterload, or contractility is altered, it's going to mess up my stroke volume. You guys get that? It's going to mess it up, which then will directly result in messing up my cardiac output. Do you see how it's a snowball effect? If I have something wrong with the pump, pipes, or pool, it's going to mess up my stroke volume, and then it'll eventually affect my cardiac output. Everybody got that? And then there's a slide. I'll show you in a minute. Cardiac output, 4 to 7 liters. Memorize it. 4 to 7 liters, or 4,000 to 7,000 milliliters. Depends on who you're checking. When we report out the cardiac outputs, we report it out as 4.2. That means 4,200 milliliters. Do you guys get that? 4 to 7. Why would my cardiac output be low? So heart failure could be one. It could be if the contractility, now we're going back to one of those things, if the contractility is off. Give me another reason. Dysrhythmias could definitely do it, right? Because now I got AFib could definitely affect it because the rate's going to be fast. It's not going to have time for the heart to fill. No one's going with volume depletion? Back to your trauma. So think about, there could be many reasons why the cardiac output could be low. It could be a volume thing again. Here we go. Okay. Now, why would the cardiac output be high? Say it again. Not always, because if I have a lot of resistance after load and heart failure, I could have a decreased cardiac output. Why? Why? Okay. Why? I used to do this and then I hit somebody in the head and I stop. But Jill brought me candy, so I'm gonna throw it. Why am I vasodilated? Could be I overdosed on beta blocker. Okay, fair. Septic shock. Loosey goosey. Wide open. Cardiac output of like 12. Okay. So do you see how these numbers are really important? And especially in the patients that you're going to be taking care of. You're going to see this. You are. Okay, so any one of these, if they are altered, it will affect stroke volume, which therefore then it affects the cardiac output.
Now, if it was high, would it be possibly, would tachycardia go with that?
No, because tachycardia, the heart's pumping so fast, it doesn't have the opportunity to fill appropriately.
Okay.
Yeah, that's back to that AFib and those kind of things.
Okay.
All right, now, cardiac output's great. Yes. Yeah, change that because I'll tell you why. Please, thank you. So on that slide, you guys change it to because I went into the literature and just found this the other day and updated it. So thank you. Change that. 60 to 70. Thank you. Okay, now cardiac output's great. I got patient A in one bed, patient B in the other bed. Patient A has cardiac, patient B has cardiac output. Right? And you're like, okay, everything's good. Not necessarily. You want to know the cardiac index. Because now, patient A might be 340 pounds. Patient B might be 90 pounds. Do you guys see that? So the cardiac index is way more specific to that patient. Better number. Now, sometimes we don't always have it, but it's way more specific than the cardiac output. Make sense? So anytime you see the word index added to something, that means I'm using the body surface area and the size of that patient. Better number, way more specific. Okay, so 2.8 to 4.2, because that cardiac output of 4 in the 300 and 50 some pound patient might be a cardiac index of 2. That's not good, is it? Might be a cardiac index of 3 in the 90-pound patient. Do you guys see that? Really important that you pay attention to the cardiac index, way more specific.
Output is kind of like an estimate overall.
Kind of. I mean, it gives you a number, and I'll show you cardiac output, and we shoot cardiac outputs, but we need the cardiac output to get the cardiac index. So we got to get there anyway. So we're going to do it anyway. Okay, so just a visual if you want to see. All of those affect stroke volume. Now, we didn't even talk about the AFib and the heart rate. I might have a normal preload, I might have a normal afterload, and I might have a normal pump. But now I have a 160. Is that going to affect my cardiac output? Yes. So do you guys see it's all important? My son was in rehab yesterday, and he said to me, I get this patient, and he's really deconditioned. I think he's a long-term COVID patient on the ventilator, very deconditioned. And the nurse took a set of vitals and had a pressure of 70/40 and a heart rate of 140, but didn't tell the therapist. So the therapist takes the patient, assuming that the patient's safe. The patient's like, oh, I don't feel so good. And heart rate's 140. Well, he's not going to have the cardiac output. You guys see that? So they had to bring him back, put him back, do orthostatics on him. And he would be laying down, his pressure was 120 over whatever, set him up, he dropped. So he's severely orthostatic. Do you guys see that? Anybody know what drug I'd give for orthostatic hypotension? Midodrine. Don't write it down, but midodrine. You might see your patients on midodrine. So it's important to know that. You know, you go in and they're laying and you get a pressure of 120 over 80 and you're like, oh, this is great. And all they do is sit on the edge of the bed and their heart rate shoots up to 160 and their pressure drops. They're not going to have a cardiac output. And they're going to be like, I'm lightheaded, I'm dizzy, I don't feel good. You guys see that? So then you go, I better get another set of vital signs. Okay. So we talked about the preload already. And here's my swimming pool. I'm visual. Here's my swimming pool. Volume status. And in the practice that I work in, volume status is very important to me. We want to know if the fluid overload or fluid volume deficit, because it can cause kidney failure both ways. So definitely we're really interested in the volume. And I showed you that too little, not enough stretch, released if I'm in volume excess. What gets released? Yeah. So, I mean, that should be the first thing. If somebody looks fluid overload in ER, I'm going to bet they do a BNP. Does that make sense? You're like, oh, I had somebody this past week and hers was greater than 70,000. Mm-hmm. Yeah, so volume excess. So then you go, oh boy, we know that there's too much preload because the ventricles are being stretched beyond what they can handle. And BNP gets released to naturally diurese the body. That makes sense? Okay. Higher the BNP, the worse the heart failure is. So there's your pipes. And again, I'm going over the concepts, afterload resistant. So, you know, if I have a really high blood pressure, it's like trying to go through a locked door or having a bunch of people holding the door closed and trying to get through. Lots of resistance. Hence where your cardiomegaly comes into play, those chronic hypertensive patients. The ventricle has to work so hard to get out that the ventricle enlarges because of hypertension. Okay, ventricle has a really, really hard time getting it out, so it enlarges. Cardiomegaly, the heart gets enlarged because of high blood pressure. So we want to get that blood pressure, that afterload under control. We've got lots of medications that I'll talk about. And then if I'm people always confuse these two. Vasoconstriction and clamp down. Vasoconstriction, I'm clamped down. Vasodilatation, wide open. Everybody got that? Vasoconstriction, clamp down. Vasodilatation. And guess what? I can give medication, which are going to hang this semester. Contractility. So we'll talk about one parameter later on. It tells me how well that left ventricle, because the left ventricle is a big pumper in the heart. We need the left ventricle to really be fine. So we want to have effective contractility. And how would we know this without hemodynamic? You guys should be writing them down. Yeah, ejection fraction. Are you guys writing down the echoes? You should be writing down the echo results. Because I had a patient who had an echo 20 4 years ago, and nobody repeated the echo. So I'm like, oh, we should probably repeat the echo. Her EF was 20. What should it be? It depends on what book you read. Some doctors are like, okay, 55. I've read 60, 65-ish. 20. So you think that patient was in heart failure? Yeah. So what do I got to do to help this patient that's in heart failure with an ejection fraction of 20? What am I going to get? Okay, so one, get rid of the fluid. And what am I going to get? Nope. You were going to get some. Who's what? Yes. Did it. Inotrope. Contractility. Already got that? If it's a pump problem, we need to give something to help it contract better. So do you see why you need to know if it's a pump, pool, or a pipe problem? Because the drugs work differently.
Injection fraction is always contractility problem.
If it's low, yes, because the ejection fraction tells us how well that, and you could probably see something that says like akinesis. It'll talk about how well that heart pumps, but yes, the ejection fraction has to do with heart failure patients more often than not. And contractility. Okay, so do you understand? If it's a preload problem, I'm going to give what? Volume if I'm depleted, right? If I've been vomiting at home, I'll tell you how many patients in practice that I'm in that come in and end up in acute kidney injury because they are dehydrated. That's it, dehydrated. So we're going to get that volume, right? Now my heart failure patient has too much volume. What are we going to do? Diuretics. Don't make this hard, you guys. Do you guys see that? If you understand what the problem is, you sure as hell know how to treat it. Now, let's go on the flip side. My blood pressure is low, so my afterload is low. What are you going to give me? If it's a fluid-related thing, but vasoconstrictor, like Levothyroxine. I think that's on your list, isn't it? Norepinephrine, vasoconstrictor. You're all right, though. If it's a volume thing, give volume. Now, if my afterload is really high, I'm in cardiogenic shock, and I have this really high afterload, what are you going to give me? Like, what's going to dilate my vessel? Is one. That's one.
Low pressure.
You could. Say it again. Vasopressors to cry. Now, yes, you said that, yeah. Okay. Trado, I don't see as much. There's some other drugs that we'll talk about to help. You could do diuretics. That's a diuretic. So you could. Okay. Now, this is honest to God, please don't study this slide. Let me say that one more time. Please don't study this slide. It's just showing you how we can get different things. So I am going to talk about the bioimpedance. I am going to talk about that because that's non-invasive. I'm going to talk about an art line. I'm going to talk about a central venous catheter, and then I'm going to talk about pulmonary catheter. There's many other things that we can do. These are the most common that I'm going to talk about. Okay? But do not think that I'm going to ask a question. Please tell me least invasive. That's a silly question. All right. So, and when I started in the ICU, everybody got a swarm. I like the swarm. It's in the heart. And then they came up with this machine that you could attach to the chest. And they said, hello, this is just as accurate as this one. And I'm like, I'm suspect. So they've done research and everything like that. So this thing called NICOM. Have you guys heard them say that anywhere? Like, we need the NICOM. Okay, the NICOM doesn't give us every single pressure that this one does, but it does give us something. So the SVI, remember what I said when you add an I, so stroke volume index and cardiac index. Okay, it can give me an SVR, but it puts it as TPR. And one of the things most commonly that we use the NICOM for is see if a patient is fluid responsive. Now, my blood pressure is low. What's the gut reaction that everybody wants to do? Give fluids. Does everybody need fluids? No. So we do something with the NICOM to see if they're responsive to fluid. Does that make sense? In my days in the early 90s when I worked in the ICU, it was like everybody got fluids. We just drowned them in fluids. Now we do the NICOM to say, well, yes, this patient would benefit from fluids, or no, this patient would not benefit. That makes sense to you guys? So you might hear them say, do a PLR. And I'm going to show you a video. I attached them down here. But the PLR, and I did this weekend, because I had this lady who was COVID positive, who ended up on the vent, who was anoxic, who cardiac arrested for about 20 minutes. And again, when your blood pressure drops, what do we want to do? We want to give fluid, right? And her kidneys were failing. So I'm like, well, how much fluid did she get? You know, does she need fluid or doesn't she need? And her BNP was extremely high. So I'm thinking, I don't know. Her pressure's still really low, but her BNP's high. So we did a PLR and there was no change in her base. I'll show you a video in a minute. We didn't give her fluid because she wasn't responding to it. Does that make sense? So I didn't drown her more. Do you guys get that? Because like I'm telling you, we used to run 5, 6, 12, 10 liters of fluid into people. We don't do that anymore because we see if the patient's responding to fluid. So we do a PLR test, a passive leg raise test.
So how are you checking if they respond to the fluid without giving them fluid? Is that a stupid question?
I'm gonna show you a video. I'm gonna show you a video. So you get a baseline number. You set them up to the NICOM, and I'm gonna show you this video. And you get baseline number. So we know the stroke flow. We got a nice baseline. Then we put him down, and do you see his legs up 45 degrees? We put the legs up, and we see if that venous return, because we're dumping a bunch of fluid back. You know, we could do a fluid challenge too, one or the other. We see if there's a change in volume when I lift the legs. Everybody got that? So let's say I start with the stroke volume of, let's go 50. I'll make it easy. Stroke volume, it wouldn't be, it'd be lower, right? Because of volume. So let's say I have a stroke volume of 50. 10% of 50 is 5, right? That makes sense. Did I do my math right? You know, I don't teach math. Okay. So if my stroke volume changes from 50 to 55, they're fluid responsive. Do you guys get that? Because it's 10%. If my stroke volume goes from 50 to 51, don't bother getting, there's no change. Do you guys see that? Exactly like that picture in the right. So by the trapezius, I'm going to show you guys a video in a minute. By the trapezius and down here. Now you can put them posterior because I had 4 patients that were prone this weekend, so I couldn't get to their chest. So you can put them posterior if you need to. Okay. So I'm going to show you a video. Hopefully we have sound. And you have access to, you can certainly watch the video at home as well. Let's see if this works. And no one's going to leave you. One of the things I wanted, you know, back to go into these units, no one's leaving you. You guys understand that? They don't trust you. So they're not going to leave their patients. They're in charge. You're not in charge of this patient. You're there to learn, but you are not responsible for this. Do you guys get that? Okay, I don't want you to think like, oh my God, they're going to leave me and I have to figure this all out on my own. All right, let's see if this works. Wish me luck. Let me skip. Here we go. Okay, skip the ad.
Yeah,
You can't, you still can't see it. I skip. Ugh. Stop share. I did hit screen share. What the heck? It's not up here. Stop share. Hang on. I have this total. It's still not. Ah. Hang on. Hang on. Hang on. Hang on. Here we go. Woo, Lord Jesus. Let me take her back to the beginning. Come on. All right. Now, why didn't I have my volume? I've changed the speakers. All right, I'll talk you through this. So you hook them up and you do a baseline. Just like anything else, you got to have a baseline. Have to have a new one. So the baseline's at 45 degrees. Now, a lot of our patients can't tolerate being at 45 degrees, but you don't want PCBs on because that'll increase the venous return. You don't want anything on. So you're going to do 3 minutes if you do not have a baseline established already. So now we're going to do the challenge. You see that? Passive leg raise. And literally I've sat in the room and held the legs up because we didn't have the pillow. So another 3 minutes. So we're looking for a stroke volume index change greater than or equal to 10%. Okay, if it is, we're going to get fluid. If it's not, we're going to do something else. I have another video that I'll show you. This is in the PowerPoint, so you could just click on it when you're at home. I don't know why I had sound. Let's look at the other video. Yes, yes, absolutely, yes. So, I mean, if I have a swan in, that's a whole nother ball game. But this is a patient who does not have a swan in. So yes, let me see if I can.
Harvard scientists confirmed for the first time that the brain dead corpse have adipose tissue levels in the body.
There you go.
That's not the right video. Hang on. There we go. I wanted to do this video. This shows you. It's a YouTube video, so you'll can get to it. It actually shows you the pillow that comes with it, and there we go. Let's see. Now, where the hell did the sound go? All right. Same concept. And again, this needs to be ordered by the resident or the critical care intensive. So a couple things that I want you to look at. The cardiac index, 3.6. Yay. Do you guys see that? Cardiac output, 6.5. Yay. Really good. So SVI, do you see it down there, 63? And then heart rate's 56. Do you guys see that? So those are the numbers that you'll see on the night phone. Non-invasive, non-invasive. Yep. And I was hoping this was the video. I showed, there's a video that there is another one. I don't. See where they're, all right, so here's our guy at 45 degrees. And where did he go? So they're doing the baseline right now. But yes, this is all non-invasive. Nurses can flip this on really quick. We can get some numbers really quick and kind of know what to do. Before I had to wait for the swan, do all that stuff.
Why would they do this one then if they have this? That's so.
So if you're doing your open heart patients, you really want to know those pressures within the heart. You want, very rarely do I see people anymore. More CVIC and they pull them out like within 12 hours. Yes, you can get a continuous cardiac output with the swan. So if somebody's really, really unstable, they might pull them in.
I just think the infection risk.
Oh, 100%. We'll get to, because wait till I show you the catheter. Okay, now watch. Literally, this company gives you the pillow. So all this test is to tell me whether I need fluid or not. It's not going to tell me about pressures and things like that. Does everybody get that? This just tells me if I'm fluid responsive or not. And she goes into the Starling's curve and this and it needs to be up there and blah, blah, blah. You can watch it. But all that this test is to say, would respond to fluid or nope, don't even bother. Make sense, guys?
If this is greater than 10%, it's saying it's a preload trauma, basically.
Yes.
And then saying it was less than 10%, you would go to other thing.
Yep.
So, just so I'm making sure I'm right. If it's greater than 10%, you're going to get fluid.
Yep.
Okay.
Yep.
And if it's less, then you're not.
No, because they're not going to respond to it because we did that challenge. Now, the other thing, and I didn't show you this, is if they can't tell going up in the air, we could just do a fluid challenge of 250 cc. Say it. Same concept. Did the stroke volume change with that little bolus of fluid? We don't want to give them a ton of fluid, might not respond to it. Does that make sense? But 250 is not that big of a deal. So it is only a preload thing. Does that make sense? Now, we can get numbers on the NICOM. The PLR, the passive leg raise test, is purely to look to see if they're fluid responsive or not. That's a preload thing. We can get other numbers on the NICOM to talk about the afterload. Does that make sense? We can get a cardiac output and an index. But the PLR, only to see if they're fluid responsive. All right. Let me escape. Yes, you have, oh, I thought you had a question. Here. Okay.
Dr. Coalmer, just so I can make sure I have this okay with it. PLR.
We'll discuss the utility of passive leg raising to identify fluid
Now
response.
the sound works. Wait a minute. Wait. Go ahead. I'm sorry.
Okay, so the passive leg raise, the NICOM only measures if you're fluid responsive. But the
No. Let's start with the NICOM. So the NICOM gives me numbers.
Okay.
The part of the NICOM is this passive leg raise. And that's just to tell me if I need fluid or not. I can do some afterload numbers. I can do a cardiac output number. That has nothing to do with the PLR. The PLR is just purely, do I need fluid or don't?
So NICOM isn't specific to that, it's the PLR that's
You got it.
specific, and that's
You
a
got it.
part of NICOM.
You got it. You got it.
How long would you leave an iPhone on somebody, like the whole entire ICU stay?
It really, it's how it's ordered. So it could be, you know, we want numbers continuously, you know, or let's do a one-time, like my patient that I ordered a one-time just to see if she would be fluid. But it's really individual to whatever they order or however they want. All right, stop share. Let's share again. Okay. Nope. There's like 42 screens here and I have to figure, it's not showing up on them. Well, it's showing here, but not here. So when you watch this video, you're not going to see it. I don't know why it's not showing up. So there we go. Please, oh man, can you, yep. All right. Are we good with PLR? Volume, 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 balloon, think balloon. I don't know why it's not switching. I promise you I'm not really stupid. I mean, I can be. Ha! There we go. Now we're going to take it up a step. Remember, non-invasive, those were just patches, right? Everything's good. We're like, let's get some fluid. Now, when we start talking about getting a little bit more invasive, now we're going to add some lines. Now we're going to put things in patients. Okay. So, but to hemodynamically monitor, we have to have the right equipment. Everybody got that? So you're going to hear people say, can you grab a claw? They're going to go, yeah, I don't know what you're saying. This is a claw. Okay. And we attach, I'm going to show you how to do that in a minute. But at the top, you can see little stickers there, arterial, CBP. Okay. And I'm going to hand this around. And PA. These are the claws. These go onto an iron pole. So you're going to need to start some sort of invasive catheter. And we're going to build the case. We're going to start with an arterial line, which I'm spoiled. Mother likes arterial lines because then I have a continuous blood pressure and I love it. Not everybody has one, but I love it. So we have to have an invasive line, and we'll talk about several different invasive lines. We have to have a high pressure bag. We'll hand these around. A high pressure bag. Because we have to exert the pressure against that vessel so the blood doesn't back up. Does that make sense? And then we specialize tubing. So let's look what it says. Pressure monitoring set. Okay. Specialized tubing. So it's got to be firm because it has to be able to tolerate the pressure that's exerted against it from the vessel. Does that make sense to you guys? Just pressure bag. Yep. All right, flush.
So like that tubing would be much firmer
Yes.
than
Yes,
regular.
yes, and I'll. Well, no, I set it up.
Okay.
I'm gonna set it up so you guys can. I want you to feel that one there. You see
Oh,
how
yeah.
firm it is? So send that back. Just give it back to me because I'll need it. So. This is the top part that's not. Down here, very good.
It even comes in like a smaller thing now.
This,
Yeah.
this is the secondary. That's the secondary.
Yeah, no, mine is in the back.
Okay. So, and that's if I need more lines. That's only one connection, but if I have a swan, I need a bunch of connections. Okay, so we need a monitor. That makes sense. We need specialized tubing. We need a flush bag, which I might have to swipe one, and a line. Okay, everybody got that? So you'll see people like walking down the hallway like this. They're like, grab a claw, and you're like, okay, I know what that means now. So other thing, you know, you have primary IV tubing and secondary IV tubing. You have primary monitoring tubing and secondary monitoring tubing. So if I have more than one line, do you think I can have more than one line? Yeah. So if I have more than one line, secondary tubing. Okay. So I'll show you how that goes. All right. So the bag And years ago, when I first started in the ICU, we put heparin in these bags because we didn't want our lines to clot off, right? Why am I not using heparin? HIT. 100%. And half these patients, I mean, my ladies' parents this weekend were 17. Why would you give somebody 17 heparin? I hope you don't. So really important. Most of the time, you're just going to see saline. You may go to another facility, but still, I can't guarantee that. Makes sense? But we're going to just use saline. This changed every 24 hours. So you got to know when they hung it. The tubing, thank you, Jesus, is every 96. So the other thing that's in here is, you see these like little blue tabs? We need to put dead enders on because they're going to be open and they can cause. Now I got you this. I'm gonna put that to you. All right. So we are going to set this puppy up. So in your room, every room has a monitor. You shouldn't have to look anywhere. Every room has a monitor. In the ICU, not in PCC. Depending on, this is an art line, you pressurize tubing, pressurized bag, and hello, something magical ends up on the monitor. It converts it into electrical energy and we get. So our job is to make sure that waveform looks okay. Make sense? And I'll talk about that in a minute. So I'm going to set this up. What do you do with IV tubing the minute you take it out of the bag? You gotta clamp that sucker, otherwise you're going to. So, and I don't know if you guys noticed, did you see this piece of this tubing? This connects to a cable from the monitor. That's the way that, if this isn't connected, we're not going to get a waveform. Okay. All right. We're going to clamp everything, otherwise we're going to wear it. Now, the beauty of this, I want to show you. I'm a very color-oriented person. You guys see that there's a red tab there? You guys see that? You see the red? Okay. Red for art line. We're all very color-oriented. We use the red line for an arterial line. Then if you look here, and we connect, this is blue. Blue, CVP or right atrial pressure. Yellow, pulmonary artery. And here's the thing, on the monitor, when we connect this, that's what color they are on the monitor. So we're like animals, we're color coding everything. Make sense? And then the stickers, oh, look at that. Arterial red, pulmonary artery yellow, CVP blue. Everybody got that? So we're matching up the colors. So I got everything clamped. And then I'm going to spike 2500 cc bag of safe. Now, I like to see my drip chamber. Sometimes people put the bag all the way up here and I can't see the drip chamber. I don't like that. You do you, but I need to be able to see it so it's flowing. And I'll show you what I'm talking about. Some people put it all the way up here and I can't see the drip chamber. You guys see that? I need to see it to make sure that the line's patent. So I keep it lower. I can see the drip chamber. Now, how much do I have to blow this up to? 300. So we sit there and we sit there. And it turns green. If you see this thing popping up out to my right below my hand, right here, it's going to be a green line that says I'm at 300. You sip a cup of coffee, you watch The Price is Right.
In the ER, I've seen some people like spike the bag with a blunt needle and get the arrow before they spike it. Is there a reason for that?
I've never did that, but I don't know, maybe it's something they were shown by somebody else. I've never did that.
I've only seen like one person do that. I didn't know if like there was a specific reason to.
Of all the years that I've set that, I've never did that, but that doesn't mean that it's wrong. See my green? So I got lots of pressure. Now, what I want to show you guys right here, this guy right here is where all the magic occurs. You see what this little blue pigtail is? So this is the transducer. This is where it takes whatever's going on inside the body to electrical energy, and we can see it on the monitor. Everybody got that? So this transducer is really important. Okay, so that's the transducer. So what we do is I'm going to slide it in the arterial side because it's red. Okay, everybody see that? You guys see? I haven't done anything yet. It's full air. Okay, this guy has to attach to the cable to the monitor or we're not going to get a signal. Already got that? Okay, so we're going to leave that a minute. We're not ready to start. Now I've got to prime this or I'm going to give my patient a boatload of air. Okay, so I use this. And I'm going to shut off to the patient. And do you see this white cap, clear cap? Correct. Because it has a hole at the end, I need to put the blue dead end on. Okay, so here we go. I'm going to open this. Now watch how fast this is.
Oh my goodness.
Yeah. So, and I do that all the time. My husband calls me a bull in the china shop. I'm messy, but I get it all done and take care. So I want to make sure all the air is out until that force. And then you have to take a dead end. And you never touch these because you're going to contaminate. So you keep your hands off that and we put it on there. Everybody got me so far? Okay, so we get it. And please don't screw this on so tight. Make sure it's secure, but we need to have these be able to come off because I'm going to show you something in a minute. Now I got to do this line, right? And again, I'm going to go to every single port and open it up and prime it. And I'm going to dead end it. Because when you guys are on clinical, and if your patient has an art line, you can draw from this. Lovely. Pretty cool. So I all the way to the end. You got that? Now what I normally do before the physician comes in to put the A line in, I connect it. So now the monitor says, hello, you've connected something, and I shake it. And I call that whip, and I can see it do this on the monitor. I know that I'm communicating with it. Does that make sense? Now I'm ready for whenever they come in with their line. Don't take that off until we connect. Okay. So let's hypothetically say, we'll make this an art line. So physicians all surgeried up, all surgical asepsis, we connect. More often than not, you see an A line in the radial or the brachial. Femoral is dirty. We don't really like to use the femoral, but in emerging situations, you might see it. Now, to ensure, what do you do every morning to get on the scale? Once a week or sometime? What do you do to the scale first? You got to zero that sucker, right? Because I'm not getting on a scale that's 5 pounds heavy, right? So I tap the scale and I wait until it shows all zeros. Then I get on the scale. That's the same concept. So what we need to do to ensure accurate readings, because I can't tell you, if you call somebody with incorrect readings, they're going to be really mad. To ensure accurate readings, we need to do 2 things. We need to level the transducer, that's that little box that I just showed you, and we need to zero to atmospheric pressure. So leveling, it aligns with the atria. So that's our reference point. So the phlebostatic axis, fourth intercostal, mid-axillary. And yes, I have a carpenter's whip. Love it. In the hospital, they're about this long. They look like a weapon. You go to Cleveland Clinic, there's a laser. So what I need to do is I need to level the transducer to the phlebostatic axis. Everybody got that? Because that's making the estimate. You're at the atria. So it's a reference point. So everybody's at the same reference point. This blue button that I just put on here, the dead ender, that's where you're going to put the level in. So let's just start with that. If you guys can't see, you can get up. But you want it level with the blue button. You guys see that? Because that's our reference point, the transducer. So I need this blue dead ender to be level with the phlebostatic axis. Does it look like it's going to be right now? What's wrong with this? Too high, right? So one of the things that we do, I mean, I don't sit down on the chair in the room, but I'm trying to be out of your way. And literally, it could be quite challenging because you're going to have to do this, right? And you're going to have to find the phlebostatic axis. Everybody got that? Fourth intercostal, mid-axillary. So you might be like, here you go. So I got to get it level, which I have it level now. And now I have to get this down. That's why it's nice when you have help doing this. Trust me, the beds are higher in the hospital, so you don't have to get down into the stupid part of the IV pool, but here we have it. Now I'm going to level. And I level, if you can't see, come around, but I level it to the blue button. And my bubble is in the center. Everybody got that? So now I'm level with the atria. That's our reference point. So we'll say I'm level here. Now, when you change their position, what do I got to do? Level it. It's the atria is moved. So let's say I've been laying supine for 4 hours, and now I'm sitting in a 45, 50 degree angle. I got to move the transducer. So every position change, you must relevel. Every position change, you must relevel. Because you got to be lined up with the atria. Have you got that?
Why?
Because that's our reference points, because it's supposed to be, that's just like, that's our reference points to say that those are accurate readings. Everybody's in that same spot. It has to be, it's mimicking that catheter is in that right atria, and it's mimicking where that catheter's ending.
So it would affect.
Oh my God, I could sit here and play with this and go up and down and just show you how the numbers would change. Yes.
It's very important to be very.
100%. I'm not even gonna go past level and zero. Now, zero, which everybody freaks out about. So back to that scale. Remember I said I didn't want to go on a scale that was 5 pounds heavy? We got a zeroed atmospheric pressure. I don't know why. I was always taught that. That's what you got to do. So that's our reference point, sea level, whatever, blah, blah, blah. So how we zero is, you see my blue cap? Blue cap comes off. And we put the stop clock to the sky. Stop clock to the sky. Now this is open to atmospheric pressure. It's open. I go over to the monitor. I hit the word that says zero. Then I walk back over. And it goes to zero, like my scale. Tap. Zero. If it zeroes out, all zeros, then we're good. If it doesn't, something's wrong. Do you guys get that? If it won't zero out, something is wrong. Oh yeah, it's a zero line. Because if I have an art line and I have a waveform and I do this, I lose my waveform because I've just observation. This is open. Okay. See why I wanted you guys to read this before you came? So zeroing and let me recap. Zeroing and leveling, crucial. Every position change, you should re-level. The recommendation is to zero once a shift. It doesn't hurt to zero anytime. You know what I mean? You're not doing anything wrong. But the recommendation is to zero once a shift. You can do it every position change. I do. To get accurate readings, we have to make sure that we're level with the phlebostatic axis, and we got to make sure that it zeros. Here's your calibration, accuracy of the readings, the atmosphere, and zeroing the transducer. So the two concepts. Your brain should say, I've got a level and zero together. I do them together. Level and zero. Patient's in the right position. They don't recommend getting numbers higher than 60 degrees. So if somebody's in hypo, and most of our patients being in hypo, they don't recommend getting parameters when they're higher than 60 degrees. So between 0 and 60 is perfectly fine. Anything higher, they say don't get numbers. I don't know why, but
Now, this may be a silly question, but
for
the patients that are like COVID and they're like, they're prone.
still mid-axillary.
Okay.
Yep. Yep. Say it again. No, they have to be, they can't bend. You know what I mean? So like they're gonna be super. Might see them in a reverse Trendelli. Just because we don't want their heads like completely down. So you might see a slight reverse Trendelli. All the prones that I saw were supine or prone, just flat. Okay. Told you I'm spoiled. I really love our class because I can look up and I can see what my blood pressure is at any given moment. However, could those numbers be inaccurate? Okay, so very important that you don't just go, oh my God, their pressure's 0. And it could be that the line screwed up. So your brain says, I got to problem solve this first. So depending on what type of patient, and all the COVID patients that I took care of this weekend, but they also were all in acute kidney injury and on dialysis, and we needed minute-to-minute blood pressures. So there was a lot of art lines to go around. So, and they were on vasoconstrictors because their blood pressures were in the toilet. So it gives you a continuous systolic, diastolic, and a mean. And what I want to tell you about this mean arterial pressure, that is more important than these two guys. Your mean arterial pressure is way more important. Students will run to me and go, oh my God, their pressure's 90/60. And I'm like, yeah. Mine's normally 90/60. It's the mean arterial pressure that talks about the perfusion to the vital organs in the body. The mean arterial pressure is about perfusion to the main organs in the body, brain, heart, kidneys. Everybody with me? So the mean arterial pressure is way more important because I could be 90/60 and have a mean arterial pressure of 72. I'm good. Okay. So the mean arterial pressure, that's what you're going to communicate this semester. Because a lot of your medications that you give, they give you parameters. Please keep mean arterial pressure greater than. Please keep mean arterial pressure between blah, 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 blah. Everybody got that? Always. It's actually like, yes, it could be a specific patient or no, it's more like discipline. So a little bit of a different number than us and renal than us, and you know what I mean? Neuro, a little bit higher because we want to perfuse the brain. People are used to high blood pressures. We don't want to drop them low. So they were. So again, it's going to be ordered by the physician. Okay. Renal's like, all right, we'll take 65. You know what I mean? Versus neuro might be like, I want a mean arterial pressure of 90 to 100. So again, really read your medication sheets. They're going to tell you exactly where they want the mean arterial pressure. They're going to tell you exactly where. Okay. Now, beauty of this is, yes, I could go in and see what's going on with my blood pressure minute to minute, especially if I'm titrating. Sorry. Weaning is bringing it down, titrating. Okay. Increased accuracy. And then definitely, I've seen a lot of times in our DKAs, they might not be ventilated, but they're so acidotic that they'll put an art line in the DKA patient because we want to know what their blood gases are. So they might not be on a vent, but we're going to get frequent blood gases on that DKA patient. Okay, so it depends on if they require frequent ABGs because you don't want to repeatedly stick that artery. Okay. Now, I want you all to close your fist, shut off your ulnar and shut off your radial. Press down on it. And I want you to see how white my hand is. Do you see how white it is? And I want you to let go of the ulnar side, the radial side tight, and tell me if your hand inside. So open your hand, let go of the ulnar side. Does your hand pink up? That's the Allen test. And that's really crucial. Even if you're going to do like an arterial stick, like when we go in and do blood gases and I have to actually stick for it, you should do an Allen's test. Because what happens is, let's say I put an art line in this radial. Okay, let's say I put an art line in this radial and I clot off over here. I need to make sure that I have collateral circulation to that hand from the ulnar side. That's why you just did that. We're saying that this is occluded off. Do I have blood flow to the hand and the ulnar side? Make sense? That's called an Allen's test. That's what he's doing right here. Now, your art lines look a lot like IVs. You are not inserting an art line. Unless you're a nurse anesthetist, and you're not a nurse anesthetist right now. So don't, they go, you want to put an art line in? Don't go, yeah. No, you're not doing that. I've never put an art line in. I do arterials. Never put an art line in. So usually the residents or the intensivist or anesthesia will put the art line in. So if you look at the patient on the bottom, his hand, there's going to be a transparent dressing. You should always look at that site. Always. And you should always do your 6 P's. How does that hand feel? Is it cold? Is it warm? Is there capillary refill? How are those 6 P's? Remember those 6 P's we made you memorize? How are those 6 P's distal to wherever that line is inserted? Because if I have a cap refill of 5 in this hand, we better take that art line out. Do you guys understand that? My hand is cold. We better call somebody to get that art line out. So make sure that you are continually assessing the 6 P's of that. I can't stress that enough. All right, so now I used to have this intensivist that would ask my students when we were in medical intensive, do your students know how to calculate an MAP? And they used to know how to do it. I don't make you do that anymore. It shows up on the monitor. But you can do your own MAP. You take your diastole times 2. So let's say it's 60 times 2. So it's 120 plus my 90. So 120 and 90 is what? 210? Yeah. 210 divided by 3. My mean arterial pressure is 70. I'm good, right? Like there's your 90 over 60. So you can calculate. The beauty of, and this is why I like ICU, because I'm lazy. Everything's up on the screen for me. I don't have to do anything. You know what I mean? It's going to give me a continual reading. It's going to give me a continuous mean arterial pressure. It's going to give me a continuous systolic and diastolic pressure. You are to never, ever give medic. Eric, did you have a question? Well, the one on the screen is going to continually change. So if you get a set of numbers and you're calculating, you look up, those numbers are different. It fluctuates. So you can, I mean, like if you just took your blood pressure at home, you can calculate your MAP because that's that one pressure at that time. I'll show you the monitor. Your blood pressure is constantly changing. It never stays 90 over 60, 91 over 90, constantly changing. So you can, but you're probably not going to get the same. Now, normal MAP. This is nationally. Memorize this. 70 to 90. So if you come to me and go, oh my God, Lorraine, her MAP is 80, I'm going to go, all right, okay. Or, oh my God, it's 40. Now we have a problem. Do you guys see that? So understanding what the normal is, then you understand the abnormal. And then, so it's our job to make sure a couple of things. That, we can read the waveform. Now, I am not, let me repeat this. I am not going to put a diagram on the exam and say 1, 2, 3, and 4. But I'm going to talk to you about it so you guys know when you look at the monitor. This peak is going to be a so you see how it's like around 1, 2, 3? Okay, and then you guys go down here. So maybe 60. You guys see that? And then this dichotic notch, aortic valve closes. You have to have a notch or that waveform is not right. Something's wrong. So we want to see that notch, and I'm going to show you a waveform on an actual monitor screen. That notch tells me that we're correct. Aorta shuts, flip, and diastole starts. Systole, diastole. So look at that waveform. Make sure that you see sharp, nice dichrotic notch. Now, couple things. So we saw what the waveform should look like. We saw what the waveform should look like. And one of the things that we could do to make sure that everything's good is we call this square waveform test. Okay, so do you see the monitor? You see that beautiful dichrotic notch in the very, very first picture. Sharp, nice. I walk over to this little blue pigtail and I pull it. And I look at the monitor, and now I'm fast flushing. That square waveform is on fast flushing. It should look like a square, and there should be a couple oscillations after. You guys see that? So square waveform, flush, 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 let go of it, oscillate, oscillate, back to my waveform. That's normal. Everybody got that? You should expect to see a nice square waveform as I'm pulling the blue pigtail. Under dampen, which I don't see that often. And they were talking about like check to make sure there's an air bubble, or if you have, and you're going to see this in the COVID rooms, they have extension tubings that go on for like 20 feet because the pumps are outside the COVID room. So we can change the bags and all that stuff in a hurry. So there's very, very long tubing. That could be an issue. That could be an issue, very long tubing. Okay. The over dampened is probably more common. Do you see how like dull this waveform is? You guys see that? It's not as sharp as this very first one, is it? Kind of that. You guys see the difference? So here's what nice sharp. This is kind of dull. Check for kinks, air bubbles. Not enough air in the bag. I don't have enough pressure. It's got to be 300, right? Kinks, air bubbles. Now, I have an art line in my wrist, and I'm alert, and I go like this. Could I bend that art line? Yes, it could absolutely be positional. So if it started off with here, the beginning of the day there, and now it's here, reposition the patient. Okay. Because it could be just me kinking my hand, or I'm trying to eat lunch, because people can have an art line. And check the position of it. Again, could have blood in there, could be air bubbles, it could be a kink. Could be no pressure in the bag. Okay, so I don't know. I had this thought that I would try to test out a next gen test. And then as I wrote this, I was like, no, because this is a little bit, so this will not, I repeat, will not be on your test. But what you may see on your NCLEX is put them in the right order. So what do you think I should do first? So we're going to level and zero, right? That makes sense, right? Right? So we're going to level and zero. Then what should I do? So the proper patient position might even be before the level and zero. And that's where I was like, oh shit, I could do one or the other. But if you're going in the room and they're sitting in a 90-degree angle, you're not going to level and zero. Put them in a 60-degree and then level and zero. So ensure the proper patient position, then level and zero. Again, I'm not going to ask you this one. I'm just trying to get you to think of test questions that you might see. Then what do I want to do? E, yep, I'm going to check that pressure bag.
And then you want to make sure it's fluid filled.
Yep, C, yep.
And make sure they're all tightened.
Yep, yes. Now I got to tell you, if this is even a little bit loose here, blood will backflow. I walked into the room, there was a puddle of blood in the room. I'm like, ah! And so make sure your connections are all tight. That's exactly right. But your job before you start calling somebody in a panic is to troubleshoot first. Did you get that? Is it the equipment? The other thing is when you have an art line, you should always the blood pressure with a cuff pressure at least once a shift. So don't trust that art line because it could be inaccurate, right? So you want to confirm normal blood pressure like you normally do at least once. And if it's inaccurate, then you should really take it out.
Do we do that on the opposite arm?
Oh, yes. Definitely, definitely. Yep. Yep. Okay, what's the answer to this guy? You got it. Okay, questions I could answer on art line right now that seem confusing to you or whatever. Yes. So underdamped could be like a kink, position. It could be a bubble. It could be pressure, like not enough pressure in the bag, so it needs to be 300. Oh, I always flip them. When I think of underdamp, I think of it as being a flat. You're absolutely underdamp. Too long of tubing. Too long of tubing. Could be an air bubble as well too. Again, I see the other more frequently than what you're at.
So you see the over damp or
More
too
frequent.
much pressure.
Well, the overdamp is like it's kinked. It's like a flattened kind of waveform. Yeah. With a long could be with the COVID patients because they put those extenders on. I mean, it's a legit 15, 20 feet from the bed. I tripped over them going into the room, but anything else on art line?
Those whole purposes continuous monitoring.
Because I'm titrating life altering drugs, which I didn't even get into yet. Oh God, yeah, you guys can draw from there, not by yourselves with an RN or your clinical person, but you can draw those gases from them. Yes, yes. I've gotten gases as frequently as every half hour. In a bad DKA. So, yes, they're very painful. So that's like, if and especially that we need to titrate, definitely ask for an art line. Don't go past go. All right. Now we're going to get more invasive. And you all have taken care of triple lumens, right? Yes, you did the dressification. Okay. So you may see a patient with Swan, a triple lumen, an art line. You might see all that in one patient. You might see them with 2 triple lumens because they need all those ports. I don't present. The only thing, and we'll talk about this in a little bit, that you could get from the triple lumen or a PICC line because it's peripherally inserted is a right atrial pressure. That is the only hemodynamic monitoring you could do from a triple lumen catheter. Everybody got that? Yep, CVP, same thing. Right atrial pressure, CVP, it means the same thing. We're going to get to it. It's coming up. I just want to tell you, though, if you see a triple lumen hooked up to tubing, the only thing I can get is a right atrial pressure. Triple lumen ends up where, guys? Superior vena cava. So it can only give me right-sided preload or CVP. Everybody got that? And that'll come up in a minute. All right, this guy. Pulmonary artery catheter or Swan Gates. Swan, like with the bird, Gants. 2 doctors. Gives me the most information. Okay, so we could do cardiac output. We could even do mixed sampling, and we're not going to get really into great detail about venous mixed venous sampling. A little confusing, so I'm not going to even go into that, but we can do some mixed venous sampling to see how much oxygen is being delivered. But we're not going to do that. I haven't seen it for a while. And then optimal infusion of medications. Now, the Swan gas has all kinds of pigtails. And depending on depending on what kind of swan they order, you can even pace through these. You can even pace through these. Now, do you see why we don't want to put this is in the heart? Okay, so here it goes. IJ or subclavian or femoral, and it goes down and it floats in my pulmonary artery. Just hangs out there. Floats in my pulmonary artery. You see where the potential of all kinds of problems with this, right? So, but it's such beautiful numbers. It makes me so happy. But there's, I mean, I had one go up into the head. I had one that ruptured pulmonary artery. So there's a lot of complications with it. Now, it depends on the size of the patient. I'll show you that. So I don't want you guys to memorize this slide. Absolutely not. If you are lucky to have a swan, they're all labeled. You see that? They're all labeled. So PA distal, proximal injectate. So what did I say blue was? What did I call that? CVP. So your brain says, oh, I see a blue port. I'm probably going to get a CVP from here. You see how they dummy it down for us? Okay. And what did I say pulmonary artery on the sticker? No. Oh, PA distal, yellow. So both of these hooked up to pressurized fluid. And I'm going to get a waveform. Make sense? Okay. The themystor, and this is a pain in the butt, has 3 ever so delicate wires. If you break them, you can't get a temperature. This is how we get a continuous temperature on our patients. And if you break them, that's it. You gotta be very delicate. It's very fragile. That's the themystor. Okay. And we need to know the temperature of the blood when we shoot cardiac parameters, because I'll show you that in a minute. Well, that is their blood. Yeah, that's their core temperature.
If somebody had to temp something fully in, could you use that for?
No,
No.
not for shooting parameters.
Okay.
Because I'll show you a video in a minute. This is the balloon port. Look at that guy. That's how they floated in. I'm going to show you a video in a minute. Special syringe, only 1.5 mLs. You don't use any other syringe. And you never pull back. You let it deflate on its own. Because if you're very rough with this, could you rupture this? If I use a 5 ml syringe and I inflate that, I could rupture the balloon. And then we can't do something called a wedge. Okay. So that's the balloon port. Never should this be inflated, only when I'm doing something with it. So there's a port here that, so it does not inflate on its own. Okay. So don't study those. If you go to critical care, you'll have a class. All right, complications. If these become disconnected to the monitoring system or to the IV, you can have an air embolus. What do you do for me? Left side. Say it again. Left side what? Yes, left side Trendelenburg. And if we suspect a huge air embolus, you'll have, it's called a Mills wheel. It's this very loud churning murmur that they never had. So if you suspect somebody has an air embolus, so this very loud churning murmur. Okay. Get them on their left side, head down. We want to trap it up in the right atria. Okay. Damage to blood vessels, absolutely 100%, or the valve. You know, I've got this balloon inflated and I'm going to show you a video of it going in, and I could rupture a valve, which is never a good thing. Why dysrhythmias? Anybody got any thoughts? Where in particular? Where? Nope. Nope. So where did I say this ended up? Pulmonary artery, right? Could it slip back into my left ventricle? And is the left ventricle excitable? Left ventricle doesn't like for you to mess around with it. If I have this catheter that's slipped back and it's banging around my left ventricle, it can cause VTAC AFib. Okay, so it's really important that we know correct place. Pulmonary artery infarct or rupture, and I have not seen tamponade from this one, but okay, maybe they ruptured the wall of the atrial ventricle or whatever. But the pulmonary artery infarct or rupture balloon. What did I do with my CI? On your computer. It is?
I thought I saw you go back that way with it.
Uh-oh. You guys got a babysit me now. Okay. If I leave the balloon inflated, it could potentially infarct the pulmonary artery. You know, area where it's not getting blood flow. Does that make sense? So you don't want that balloon really inflated. Absolutely not. So it could rupture. Pulmonary artery could infarct it. Now, so here's, well, my job before they put the swan in is I had to get everything ready. So I need 2 more lines, right? I need those secondary lines. I need a PA line and a CVP line. Does that make sense? So I get this all set up and the surgeon or physician, whoever, he dealt with the catheter. Does that make sense? I stand there and I look pretty and I look at the monitor. Well, he's inserted because he's very focused. So the first thing they do is put in a big introducer, okay? Whether it's the subclavian or the idea, but there's a big introducer. And in that introducer, they thread this catheter. Make sense? So as he's threading this catheter, I'm watching the monitor to see these waveforms. So if I see this very first little one, see how it's like little subtle? I say, hey, doc, you're in the right by the waveform. He inflates the balloon, floats it forward a little bit more. Now I have these very sharp line on the ventricle. Hey, doc, you're in the right ventricle. Oh, I see a PVC. So I'm watching the monitor because he's banging around that right ventricle. Okay. I see it float forward a little bit more and I go, hey, doc, I think you're in the pulmonary artery. And that's that waveform. So the third one. And then he waits till it wedges. So at the end, you see that pulmonary artery wedge? He's trying to make the catheter wedge. So the waveform doesn't, it looks a lot like the CVP on the left, doesn't it? Or the RAP, whatever you call it. They look very similar, don't they? The waveforms. So I say, you're wedged. He gets a number. He deflates the balloon. He inflates the balloon again, tries to wedge it again. Number, deflates it. Then we edge it. Make sense? So I'm watching as he's advancing this catheter. So to answer, I think your question is he will tell me how far he's marked. Big fat one's 50, small one's 10. So that's 60. Oh, we're inserting it at the 60 or whatever it needs to be. Everybody's different, so I can't give you an answer how much will be sticking out. So whatever we have left, I usually coil like this and put all underneath sterile, translucent dressing. I don't want anything flipping around in the bed like this. Make sense? So whatever I have left sticking out of my body, I usually coil up and put underneath that sterile dressing so we don't have it flipping around in the bed with them. Make sense? Say it again. Oh, I didn't tell you. I'm gonna tell you. I didn't tell you yet. The wedging gives us one of those 3 concepts that I talked about at the beginning of this lecture. So I'm going to tell you. I'm going to tell you all of those as we work our way through that Swan-Ganz catheter. So again, here, right atria. So anytime I walk into the room and this catheter is in, right, patient's in the bed, I should see a right atrial pressure or CVP. Either one, they mean the same thing. RAP and CVP mean the same. Continuous reading on the monitor. I already have it in. This is not insertion now. Never should I see a right ventricular waveform except for insertion. That means my catheter, if you walk into the room, you went to break, came back, and they've had this one in for a while, that means that catheter slipped out. You get what I'm saying? It's no longer floating in the pulmonary artery, it's banging around right there. Okay. PA pressure should be continuous. And then this PAOP, which I think you're asking about, which we'll talk about in a little bit, that's your wedge. You should only see that when I inflate the balloon. So I gotta physically do something with that line when I inflate that balloon. And I'll tell you what all of them mean in a minute. So let me show you, hopefully this will work. Stop. So another YouTube video. So this will show you the insertion and what it's supposed to look like.
An arterial line just hang out like in.
That's all you get, nothing else, just a blood pressure. Nope,
Okay.
nope. Art line, just a blood pressure. Yep. That's exactly right. Yeah. Ooh, you can see that. Okay, good. This doesn't have sound. So let's say we're at the bedside and they're putting in this one. He inflates the balloon and I say, oh, and I see this waveform, right? So I know I'm in the right atrium. Now watch when we switch into the ventricle. Look at how sharp, because the ventricle's stronger. Look at how sharp. And then now that I know I'm in the pulmonary artery, see how it softens a little bit? And now it's going to totally flat out because I've wedged in a branch of the pulmonary artery. He deflates, slips back, and he's going to inflate again. At this point, because you can get it through wedge and we have the appropriate waveforms, we're going to X-ray it. Make sense? And you have that on your PowerPoint as well.
So it would go back to it. It would go back to that way.
No, it's going to constantly stay in that. If I see that really sharp dramatic waveform and the swan's been in, I'm not going past go and I'm calling immediately for help. Well, we do if it's ordered. I didn't get to, well, you guys are jumping the gun, but we do. We need to make sure it wedges so that we're in the right place. He will order how much wedging we are supposed to do. Again, that's back to that NICOM and the amount of time to order stuff. All right, so let me go back to slideshow. Okay, couple things. Then we'll take a break and then we'll come back and finish up. You know what CLABSI is? I'm sure you've heard of it, right? Yes,
What?
CLABSI?
No.
No? Central line associated bloodstream infection. So here, this beautiful patient comes into the ICU with no infection, and we throw all these lines in them. And now we've caused them to be septic. So we're very, very cautious. I had a student when I was still working say, I want to change the central line dressing. He comes in with tape that's wrapped around a stethoscope, a 2x2. I said, you can leave my room now because you don't know how to change a sterile dressing. Gown, map, you know, the whole deal, like you guys just learned last month. Well, patient can't be now, so probably on that. Has to be sterile procedure. These patients die of sepsis, come in for something else, and we've made them septic. So that's a big deal. So always sterile dressing. Don't get really stuck on this, but it's really recommended when Joe talked to you about vents to read the numbers at the end of their expiration because of the change in the thoracic pressure, blah, blah, blah. Most of the time we just take a look at those numbers that are on there. I don't focus that much. Sometimes with the peep, when I'm shooting, or not the peep. Wedge, I do look at end expiration because we get a more accurate number. So you have to watch patient breathe in, and down, exhale, and just when you get those numbers. I don't see them doing that much anymore, but it's supposed to be more accurate. Interpreting abnormal waveforms and trends and so you got to know if this looks normal or not. So if I said to you right now, pulmonary pressure 70/40, what are you going to say? You have no idea. Do you? Yeah. 70/40, but I think there's a lot of pressure in that pulmonary artery. So that's what we need to do, is be able to make those judgments of what is appropriate and what is not appropriate. Observe for dysrhythmias. Spontaneous wedging is when I walk in the room, I should see a PA waveform, not a wedge waveform, because I got to do something to wedge it. Okay. So if I see a wedge waveform, that means it's wedged in a branch of the pulmonary. I got to fix that, right? Because it did it itself. Spontaneous means I didn't do anything to it. I didn't inflate the balloon. It just wedged. Have the patient cough or suction them if they can't cough, they're unresponsive. Turn them in bed. See if you can unwedge it. If you cannot get it unwedged, they have to come and manipulate that catheter. You are never to advance or pull back on that catheter. That is only the physician. You got that? You're never to pull back on that catheter or advance it. So if you can't get it to unwedge, you try turning, you try coughing, you try suctioning, then you got to call somebody. Because spontaneous wedge, because of pulmonary infarction. Okay, and this is what I just said. Right here. Oh, and I gave it to you. Oh, geez. All right. So I just said that. Call a physician if you've tried, because he's going to have to pull back on that catheter. And if he manipulates that catheter, we got to x-ray it again. If he puts it forward, pulls it back, x-ray it to make sure it's in the right place again. All right, take a break. And then we'll do the pressures. Don't you love this stuff? It is.
Inflated when it's just hanging out in there, right?
Nope, it's floating around. That's why the potential for dysrhythmia could be. Nope. That's right. Yeah, I did.
What's the grapes? Hey. No, it's
Dr.
not.
Coalmer.
Yes.
Question.
Yes.
This might be a dumb question. So, you know, we're talking about all these numbers and going in the pulmonary artery and monitoring. What condition would the patient have? Like, is there different conditions, like, for us to be able to manage?
Just the basic.
Like,
Why am I putting a swan in?
Yeah.
Because I don't know what the hell is wrong. So somebody comes in through, ER that's hypotensive. I don't know if they're septic. I don't know if they're in cardiogenic shock. I don't know if they're in hypovolemic shock. So we put this in and get numbers and they go, oh,
Yeah, I'm glad.
cardiogenic shock. Here's how we treat. So it's a very diagnostic tool. However, like your open heart patients, because we've done surgery on the heart, they want to measure those a little bit more frequently than like something like on the medical unit. So you might see swans down in the CDX more so.
So it's really to determine a condition rather than due to like giving poor condition.
Well, it could be one or the other. Okay, so let's hypothesize and say, I'm thinking of what is her name? She's the heart failure specialist. And she's manipulating
I've never even.
the drugs to get this patient optimized. She may put in a swan because she wants to see what happens when I give this particular drug. So it could be
So
another reason. It's not,
when she gave them a medication,
Mhm.
so you wouldn't say that she's gonna find exactly what that medication did. Cause like we might say like, oh, it fixed them, but we need to know what it does. Okay.
So, and that's the reason why I like the swans was, I always thought I was like super nervous. Because they'd give me a diuretic and I'd get the diuretic and I'd see my numbers change and I go, I fixed this patient. It was really the diuretic, but you get this immediate gratification of, damn, that drug worked, or, oh my God, that didn't work at all. So that's the part that's really nice about having this one is I can see that instantaneous drop in those numbers. That's what I see.
So all this stuff we taught like at the beginning, like like say they have too much fluid or something, and you're measuring that, yeah, just like giving the diuretic.
Till the very next day, till the very next.
Yeah, yes, it's like the next thing I'm gonna talk about is right atrial pressure. So we go in and the right atrial pressure should be 2 to 5 and now it's 17. I know they're fluid overload. I give a diuretic, I call the doctor back and say I'm down to 10. Do you see what I'm saying? So it's instantaneous gratification. Yeah. Hang on, she's ahead of you. Go ahead. Mother?
Yeah,
Yeah.
okay, sounds like.
Yeah, you're supposed, you'll see when we do it.
Yeah, okay.
Yeah, you can't find a lot of them. I will make the students get it when I'm on clinical to show you. You really should now. This clinic has laser ones that are really nice, so you don't have to like flip their arm up and do all this. Yes, but yeah, you're right. Yeah.
Okay.
But I have to go by the book and do it. Yes.
So a patient can basically either have a card or the PA.
You
Just
get a
depends
both.
what they're looking. You can
No,
have
you get a,
both.
oh, God.
It's just a placement difference.
Yes, correct. One's in the artery,
Like radial, brachial, and the other one's
is in the heart.
in the heart. Okay.
Yep. This is only systemic, like getting this blood pressure and that's it. That's it.
And then it's basically just to get more specific measures than you would.
Well, I need the blood pressure and the swan if I'm doing cardiac pressure, which I'm gonna go through right now.
Okay.
Because it wouldn't make sense to have a swan in without an heart. So if I'm gonna go that far, I'm gonna have an heart.
Okay.
But I could just have an heart because my blood pressure is really high and we're trying to titrate medication.
Okay. And then that's when you do the continuous monitoring of like the longer to see.
Oh, yeah, but like we were just talking about medications and affecting the blood pressure. We want to see that. We want to say, oh, that medication works. It didn't.
Okay.
Yeah, yeah, we'll get into that in more detail now.
So, over this one's not as common. Okay, I was gonna say, have you, I've never seen that, I've been there almost 2 years. And I'm like,
They don't do it in me. There's no way.
oh, okay, so you said in, you said in your. They said they've never seen that.
ER, this?
Yeah, no, our yes.
Yeah, yeah, no.
Okay.
Yep. Are we back? Because Jill's gonna kill me, but she took long this morning. I never, so here's us talking and asking questions. So I haven't stopped.
I hope they do. I hope they do, because I.
Yes.
Had a 393.
I don't think that's it.
You too.
So, I mean. But, I mean,
Okay, let's get started. Jill's gonna kill me. Okay. Who remembers preload, afterload, and contractility? Do you? Now, we're gonna measure it. We know those concepts. Now we're gonna measure it, okay? So, where's your fabulous 1970s heart? Okay, you made me nervous, so I checked. We are still recording. So let's pull this out, because now we're going to add color coded, however it's supposed to be like that. We're going to add things to this beautiful heart. So the first thing we're going to do is in this right atrium, we're going to put our AP or CVP. Now, depending on who you talk to, I'm old school. We used to call it central venous pressure. People now call it right atrial pressure. I have both on the exam. So in this right atrium, if I have a triple lumen and only a triple lumen, I can measure the right atrial pressure. So the right atrial pressure, remember I said divide the heart in half. Right atrial pressure is your right-sided preload. Everybody got this? Because can I have one side of my heart fail and the other side not? Yes, I could have left-sided heart failure and right-sided, right? So if I have a triple lumen, that's the only thing I can measure is the right atrial pressure. Everybody got that? But if I have a swan end, and the reason that this magical little catheter knows is because the right atrial pressure, the port to measure it, is in my right atrium. Do you guys see that? So there's different holes on this catheter, and that's where it measures it. Make sense? Okay, so memorize 2 to 5. That's your normal. Okay. Now you might read it as centimeters of water. I always do it in milliliters of mercury, so 2 to 5. It's a little bit different with water. Again, right, circle that, star that, highlight that. Right-sided preload. Now, and if this may be the question that you were asking, how it says right ventricular preload. The right atria and the right ventricle, when that valve is open, are one chamber. Everybody got that? So it's giving me an estimate of what's going on that right side. So even though it says estimate of right ventricle, it's not in the right ventricle. Do you guys understand that? It's when that valve is open, it's all one chamber. So it's an estimate of the right ventricular preload. Just right-sided preload. Doesn't matter if it's atria or ventricle, it's all one side. And when I walk into the room, whether it's a triple lumen or a swan, I'm going to see that on the monitor. I don't have to do anything. I don't have to touch anything. It's a continuous reading. Just walk in and go, oh, their CVP is this. Make sense? Okay. Continuous. Continuous. Now I can do a pick too. Why? Why can I do it? Where does it end up? I don't like it. I'm a purist. I want a triple lumen or a swan, but you could do a pick as well. Superior vena cava, yeah, it's peripherally inserted central line. Oh, yes. Triple lumen, not the pulmonary artery catheter. If I remember, everybody back up. I can get from a triple lumen or a PICC line, the only parameter is CVP because it ends up right there. So it has an estimate of the right. I can't do anything else, just the CVP. Triple lumen or PICC line or a swan. All of them can give me the CVP. Okay. Only value is right here. Only value to obtain by a CVC, central venous catheter. Swan can give me a lot more because it's further in the heart, right? Okay. Second preload. It should look like this on the monitor. So I walk into the room, the patient has a central venous catheter or a swan, and we're continually monitoring the CVP for right atrial pressure. This should be on the monitor, right? I'm doing nothing. I get this number and I go, oh, I know what the CVP is. Do I know if it's accurate or not? What did you guys forget? I just walked into the room. What should I have done? Hello, I should have leveled and zeroed it, make sure that I'm at the right spot, right? So students will come running to me and they go, oh my God, our CVP is 40. And I'm like, oh, okay. Well, they're up sitting in a high position. The transducer's not letting. So don't get excited about numbers until you ensure that you are leveled and zero. Everybody got that? Now, could the CVP go to 40? Sure. Okay, so do not obsess about ACV waveforms. It should just be this nice little waveform. I'm not going to ask you that. Okay. Now, if we think about this, and I have a high preload, a high RAP, right side of the heart. So my little guy right here, I put CVP, RAP, on the right side. And I put 2 to 5. And I visualize that number. These could be the causes. You know fluid overload, right? You know this. Now, what you might not have thought about is when you're thinking of COPD, because the lungs are so non-compliant, causes pulmonary hypertension. Everybody with me on that? If it's a significant amount of COPD, it will cause pulmonary hypertension. Now, there are people who have pulmonary hypertension that are not COPD patients too, right? I'm sure you've read that somewhere. So pulmonary hypertension, and we'll talk about how we fix that. Severe left heart failure because everything just keeps backing up, right? Okay, cardiac tamponade, PE, COPD. They can tell on autopsy somebody died of a massive PE because there's a huge amount of right ventricular strain. I've got this massive PE and this right ventricle fails because I can't get past the PE. You guys see that? So that's how they can tell. Okay, they look for right ventricular strain. Somebody with PE. What do they look like? Those all make sense, right? Fluid overload. Right? Pitting edema. Now, please don't do what a lot of people do. They look at PE. They go, oh, they don't have edema. You got to touch it because sometimes, even though they look very thin, you press and it's pitting, especially in the dependent areas. So make sure that you're really looking for that. They're going to have weight gain too. I can't tell you how important the weights, the daily weights on the ICU patients are crucial. That tells me whether they're losing volume or gaining volume. Okay. I had a patient that I took care of for 3 months in the ICU. She was up 100 pounds from fluid. Not because I fed her great, because of fluid. You got to pay attention to those things. Okay, so your brain says, I already know this. How do I treat fluid volume excess? Hello. So now you can't just say diuretics to me. What do you want to give? What do you want to give? Lasix. Okay, so a loop diuretic, okay. So we're gonna get. So if they're a heart failure patient, a cirrhotic patient, we can give aldactone, okay? Oh, so is there a drug that you learned in 232 that helps with preload and afterload? Yes, there is. I know there is. 'Cause I teach. Perfect for heart failure patients. They should be on it. Say it again. ACE inhibitors. ACE inhibitors are the gold standard for a heart failure patient because it decreases preload and decreases afterload. One pill does both. So I like where you're going with the furosemide. And they were talking a little bit about it, like you guys, when you're doing your med sheets. And I did a furosemide stress test dose this weekend on my patient who's COVID, who cardiac arrested, who ended up in the kidney injury. And we gave her a big dose because we wanted to see if she peaked. Stephanie took care of her this weekend for me. And so I give her this big dose because I want her kidneys to work. And she didn't respond. So she's now going to probably transition to chronic renal failure because we can't get her kidneys to function. But it's important that you get back to the person who ordered that and say, you know what, here's your response to your diuretic. They're going to ask you. Great that the K dropped. It's a loop diuretic. But they want to know how much of urine output. We do hourly outputs. Hourly outputs. Not once a shift, hourly output. It's really important that you say, hey, the response was 600 or the response was 50. They need to know that because I didn't give another dose of Lasix. She didn't respond. Do you guys see that? So it's really important not only med, but to think, what do I need to do next? What do I need to, or who do I need to communicate what happened when I did this drug? Vasodilating. Nitro, I think you guys brought up earlier, does a really nice job. And when Deb Phillips talks to you guys about pulmonary edema, Tridal, great because it decreases preload and afterload, more so on the venous side. So that's why we give it. Okay. But it dilates if that's an issue. Okay. And then definitely patient's response. My God, you better, and I can't tell you how many times I write an order, strict INO, and I go into the strict INO, and there's like no INOs. So how the hell do I know if the drug that I ordered was effective or not? Nothing's charted. Strict INOs.
So, the afterload, you said that nitro decreases preload and afterload, right? So if they have a low afterload, that means that they look like the toilet paper.
Yes,
So why would you give them a vasodilator?
you wouldn't. So we only have one number. We only have the CVP right now. So that's why all the numbers are really important. You wouldn't.
Basically, I'm just trying to like wait this time.
Yeah.
So basically, going by this, I mean, measuring the flow, those you're going with the volume and also how their dates are looking at it. Strict data
No,
or-
we're not even in the afterload yet. This is purely volume. This number. We're gonna get to the other ones. We're just, are they fluid excess or fluid deficit? Yeah, yeah, and again, we'll know that because we have other numbers. We're just saying if I only need the CVP, nothing else. We'll get to those other things. I like where you
I'm
guys are
sorry.
going.
With the, because some of these, like the ACE inhibitors and the nitro, you said decrease preload and afterload.
Mhm.
If we only know this, would we give that not knowing?
No, so they might already be on it from home is what I'm saying. But if it's something like pure fluid volume excess, you go in and they're 4+ pitting edema, they're up 17 pounds, we're gonna give a diuretic to try to unload. Yeah. Again, you guys, we only have one number. If we're just purely talking that the CVP is altered, that's how we retrieve it. If we have everything together, which is when you'll get into the shock lecture, you will put all those pieces together. Does that make sense?
Yeah, okay. And
Yeah.
then figure out what medication
Yes.
would best work for. what.
Yes.
Okay.
You got it. You got it. Okay. So on the flip side, think fluid volume deficit here, right? Because it's preload. We're only talking preload right now, guys. We're not talking about anything else. Now, the preload can be low if I'm massively vasodilated. Explain why. If my pipes are loose and open, does it look like my pool's empty, even though I didn't lose volume? So instead of having a pipe that's normally like this, now I have a pipe like this. Does it look like I have less volume? That's what that's talking about. Does that? So vasodilating, even though I might not have lost volume, it appears that I'm volume depleted. Okay. Then we get into the afterload thing. Adding those pieces makes it so important. Let's just say I'm a trauma and I'm bleeding, or I've been throwing up and I'm volume depleted. And we'll just go with that. So to the right, you can see, you've learned this from 110, right? Volume deficit, right? Those all make sense. What is, and I don't see it, but they're very narrowed pulse pressure. You might want to write that in. What is a narrowed pulse pressure? They're closer, right? So a narrowed pulse pressure is systolic and diastolic are closer. A widened pulse pressure is 200 over 40. Very wide pulse pressure. Very narrow pulse pressure, 80 over 70. You guys see that? So you'll see a narrowed pulse pressure and volume deficit.
So narrow pulse pressure in the pulse.
Well, narrowed pulse pressure. Pulse deficit's different. That's a narrowed pulse pressure.
Okay.
Yeah, there's the deficit.
Okay.
Okay, so what do you do for me that's bleeding, vomiting? You give me volume, right? So let's say I have a CVP of 0. What should it be? 2.5. Give me volume, right? If I have a CVP of 25. Don't make this hard, you guys. Just think about what the concept is and how you treat it, right? All right, so give them back their volume. Send me to surgery, fix my gunshot wound, whatever it is. Stop my vomiting, whatever it is. Now, let's say I filled up the swimming pool and my pressure's still in the toilet. We may add some other medications. Does that make sense? But really correct, give them back the fluid. But if they're really, really a bad trauma, and no matter how much blood you throw in them or how much volume, and they're still hypotensive, we may add medications. Does that make sense? This, Levophed, epinephrine, both are vasoconstrictors. Clamp down, both are vasoconstrictors. So if I have a low blood pressure, I would give those. Okay. But again, if I know it's a pure volume issue, give it back to me. 17, 18 units of blood, whatever, give it back to me. I still can't get that blood pressure up, then you might add medications. Okay. All I want to say about this is only should see this on insertion, not see this any other time. If you walk into the room and see a large right ventricular waveform, your catheter has moved and you need to call somebody to advance it. It is slipped back the artery into the right ventricle. Don't go past go. Don't be trying to do stuff. Just call the resident. Everybody got that? So you should only see that on insertion. If you see it when you're walking into the room, call somebody to advance that catheter. It has to float it forward. It slipped back into the right ventricle. So again, should not see this only on insertion. If it's been in a while, it should be that guy or that guy. Okay.
Why do we care about the normal pressure level?
Because as I'm going in, I have to document. I don't care about that. But as he's going in, I would document all those pressures.
So it's only the value's only.
Right. Because and interesting, if the right ventricular pressure is 70 over 40, we know we've got a lot of right ventricular strain. I can tell him that as he's inserting. Holy crap, your right ventricular pressures are this. So I used to do like a napkin and jot down all the numbers as he was inserting. Yep. Okay. I used to separate these out. We're gonna keep them together because there's pulmonary artery systolic, pulmonary artery diastolic, and then there's a pulmonary artery median. Think of it, it is not, put this in really big, it is not an arterial blood pressure. Let me say that one more time. It is not an arterial blood pressure, and I'll tell you why I'm telling this story. Somebody drew blood gases from this pulmonary artery catheter. Why is that wrong?
That's deoxygenated blood.
Hello. Basic physiology, basic understanding of what the heart is, and they treated those. The physician treated those because he thought she got a blood gas. Well, it's a pulmonary artery. No, it's deoxygenated blood. The pulmonary artery is deoxygenated blood. Does that make sense? So you are not, I repeat, you are not to get arterial blood gases from a swarm. Only from an art line. Only from an art line. Okay. So in the pulmonary artery, you're going to see it red like 20 over. You guys get that? You're going to see that on the monitor. And that's good. I'm going to move on from that. That's good. But if I see 70 over 40, holy crap, this patient has a lot of pressure in the artery. Does that make sense? Okay. So very important that you know those, so you understand the abnormals. Okay. This is continuous. I don't have to touch the patient. I walk into the room, it's on the monitor. It looks almost like a blood pressure, doesn't it? It's not. Let me say that one more time. Blood pressure. So very important that you know that. It is not a systemic blood pressure. I can't say that enough. So you're going to get a continuous waveform. And I combine them, but think about if there's pressure within my pulmonary artery, think about the things that can cause pulmonary hypertension, a lot of pressure. COPD is a bad one. ARDS, when Jill talks to you guys about ARDS, that's non-compliant lungs, very rigid lungs, very hard to oxygenate, lots of pressure, okay? So, do you know what drug I give for pulmonary hypertension? Say it again. Oh, you smart ass. Viagra.
Yeah.
Yeah. And I remember the first time I gave Viagra, I was like, this is a woman and it's an ICU patient. And like, nobody told me that it was pulmonary hypertension. I only knew it for, you know, and then I was like, oh, okay. So originally that drug came out for pulmonary hypertension. But then they found this wonderful side effect and forgot about pulmonary hypertension patients. And I don't even talk about it. So how do they look? Think heart failure-y kind of patients. Now, if I have right-sided heart failure, what's that called? Nope. Right-sided heart failure, fancy Latin word. Cor pulmonale. Okay, so I can have right-sided heart failure due to my bad COPD. Everybody with me on that? I could also have left-sided heart failure, so I had a heart attack and it keeps backing up into the right side. You know what I mean? Eventually you can get that back. But we can have cor pulmonale with COPD patients. They have the peripheral edema, all those things that you remember from heart failure on the right side. So it's important to know that, you know, and again, getting their echo will be very, very helpful because that'll tell me how the left side's doing too, right? All right. So crackles, edema, JV. And you guys know all that. What are you going to do for this guy? You need. Oh, I thought you were coming Thursday. Is she on it? A girl said you're on the schedule. Give me, I want to finish because Jill got me behind, and then I'll have you come in. Okay, great, Erin. Thanks. Is she on the schedule? Write the schedule. Jill put me behind, so I want to get this done. She'll come. Okay. If it's a volume thing, and I would know CVP would be up, right? If it's a volume thing, I might be on a fluid restriction. Again, think your heart failure patients, right? And I might give diuretic. That makes sense too, right? If it's a volume.
If it's a vasodilation, or be a vasoconstriction if the pressures are.
Yes, so if the pulmonary artery, if they're pulmonary hypertension, it's gonna be a lot of pressure. Hence why the Viagra works because of the loosening. Yep. So administer pulmonary vasodilatation medications, Viagra's there. Velitree is another one, and Russ gives that through the ventilator. And then cardizem, which I haven't specifically gave for pulmonary hypertension, but I've given it. But they're saying that cardizem can do it as well. If they have a failing heart, we're going to give that positive inotrope. So the IV or PO, but the Jackson's a pain in the ass because it takes, you have to load them. It takes a while to work. You might see them on dobutamine, which is another positive inotrope that's a continuous IV medication. Okay, might be one of your drugs that you with that. And then again, you see the ion, the daily weights, and all those consistent things, rest periods and that kind of stuff. If it's low volume deficit, give me back my volume, right? And again, I probably, if I know a pulmonary artery pressure, I'm going to know a CVP because that's part of this one, right? So, okay, good. So if I have a pulmonary artery pressure number, that means I got a swan in, right? That's the only catheter that can give me a pulmonary artery pressure number. I know that I'm going to know the CVP as well. Do you guys see that? So I can really make that judgment of CVP is 0 and the pulmonary artery pressure is 9/4. Very low. You guys see that? Now I'm like, oh, I got to get back volume. You guys see that? Okay. Again, give me back the blood if I'm bleeding or if I'm puking, stop my puking volume. Okay, so you guys asked about this. Let's just pause a minute and refresh. You got a CVP or a right atrial pressure, so you put that in that right atrial, right? 2 to 5. Tells me volume status. Then we work our way down the catheter. We skip over the right ventricle because nothing should be there, right? Now let's get into that pulmonary artery and let's write those numbers 20 to 30, either 15 or whatever it is. 12. Depends on what book you're in. Okay, so now we have our pulmonary artery pressures in that pulmonary artery. Everybody got that? Now we have to physically do something. So far, all we did was look up on the monitor. Now I gotta physically do something. You with me? So now I'm gonna inflate the balloon. And you say, well, Lorraine, what the hell are you doing that? The wedge tells me what the left side of the heart is. The wedge tells me now, is this catheter all the way over into my left side of my heart? No, because I'd have to go through the lungs and then into the left atria. You made me behind. So I'm almost done, I promise. So it's an indirect measurement. So on that left atria, I want you to put wedge. And it's slightly higher than the CVP, isn't it? And the way that do you remember in the video, the balloon inflated and went forward, and it kind of in that branch of the pulmonary artery. So it shuts off what's behind it and only looks forward. So if we visualize that that whole circulatory system is all one open, it's telling me what it looks like the left looks like. Indirect measurement. It is not in the left atrium. Okay. You might hear it as PCWP, you might hear it as PAOP. So here's the picture. We inflate the balloon, one little branch, shuts off behind and looks forward. So it tells me this indirect measurement of what the left side looks like. Because remember, can't my left side fail versus my right? Okay. Remember, you let the balloon down passively. It should look a lot like the CVP, a little bit higher number. Do you see that? Okay. So what is preload again? Volume. Now we know the left side of the heart volume problem, right? So if the volume is up on the left side, what are you gonna give me? The blood pressure can tolerate it. You guys see that? If my volume is up on the left side, what am I gonna get? Diuretic, right? Same thing with the CVP. CVP is high, wedge high, right? They're both preload. One is just on the right side of the heart, one is just on the left side of the heart. They're both the same concept, preload. Make sense? I need some nods. I'm losing you. Okay. You guys are making me nervous. So what do we do for a high wedge? Well, diuretics, if it works, right? Fluid restrictions. We'll see that a lot from renal disorder, fluid restrictions, sodium restrictions. If it's an issue that we know the EF is down and a contractility issue, positive ion trace. If it's an afterload issue, then we're going to dilate, right? So I think Joe probably had you guys look up nitro press. Does that sound familiar? And then, oh, look at that ACE inhibitor. What did I say about that? Now, these are acutely ill people, so we don't go, here's your catheter. We're going to try that today. We're going to do things IV first, right? And then maybe when I go home, I get put on that ACE inhibitor. Does that make sense to you guys? When they're acutely ill, we got to do something right now. So you see all these IVs? Literally will be that many in the room. Again, preload, left side of the heart. Restore my volume. See, doesn't that make sense? If you just think left versus right, restore my volume. All the same things with decreased fluid volume deficit. If I'm bleeding, give me blood. If I am just vomiting and losing volume, they're going to probably give me IV fluids, right? Whatever the issue is. Daily weights, strict INO, I can't drill that in your head enough. So I broke this down again to remind you. Right side CVP, left side wedge. Make sense? It's just reiterating it, saying it all over again. So I want to show you this slide. This is what your rooms are going to look like. So your EKG is always green. You like that heart rate? I did. I don't know about you guys. Can you tell what kind of, ooh, I don't know if they have this yet. Can you tell what kind of rhythm that is?
We're not good with rhythm.
It's a what?
We're not good with rhythm.
It's a pacer. Do you see these spikes? They didn't, I couldn't remember. Okay, good. Now the red. I want you to look at the red. That is your art line. What do you think of your mean arterial pressure of 63? So what are you gonna do for me? Oh, I don't know. Look at your CVP. It's 20.
Can't I give you, vanilla?
Oh, no, that'll drop my pressure even lower. Oh, well, you could. She said, could I do the PLR? You could, but look at your CVP. Is 20 normal? So what might you give me to bring my blood pressure up then? Yes, levofen, epinephrine. Okay, take a look at. So do you see the word wedge? See the wedge? Look at your pulmonary artery pressure, 41/25. Do you guys see that? Is that high or low? Yeah. Right? And look at your wedge, 16. Should your wedge be 16? So that's high, right? So we know both the left and the right side of the heart high preload, don't we? But we have a low afterload, don't we? Ooh, what's going on with this patient? So do you see how all the numbers play a part in figuring out what to do? Like, it'd be great to give a diuretic, wouldn't it? But do you think their blood pressure will tolerate it?
I mean, then you have to like increase the contractility because it's not getting it out enough.
Knowing my echo and knowing what my EF is will help me as well. Do you see? So every piece of your patient's chart is crucial. I mean, there's not a, oh, I shouldn't write this down. The echo is so important because that's how, and everybody gets an echo. I think nowadays, everybody gets an echo. It's so important to tell me how well that heart's contracted, unless they have a heart cath. They go to heart cath. But yeah, you got to know everything. Yep. All right. Afterload is going to be your PVR. So in your right ventricle, I want you to put PVR. That tells me how much resistance I have to go against to eject out of my right ventricle. SVR, think of your blood pressure. That's how much the heart has to go against to get out of the box, to get out of the heart. Okay, so left ventricular afterload. So on the left ventricle, put SVR. You absolutely do not need to know these formulas. Absolutely no, but you do need to know PVR is only 50 to 250. So somebody with COPD, what do you anticipate PVR being? Yeah, PVR might be 400. You're like, oh boy, really high, right? Because that ventricle has a lot to work against that pulmonary hypertension. So really, really high. So we're going to, cause could be massive vasoconstriction for whatever reason. Hypoxemia. We're going to get pulmonary vasodilators, just like that Viagra that we just talked about. Okay. Or a calcium channel blocker. Okay. So your PVR is a calculated number. You don't do anything except hit a button to get a cardiac output, and then it does all this magical math for you. Like Debbie Phillips, you can calculate these on your own in your own brain. But I am not Debbie Phillips, and I can't do these formulas. She knows all these formulas. So your SVR, normal SVR, my straw, 800 to 1200. SVR over 1200, coffee stirrer. SVR below 800, toilet paper roll. Everybody got that? That's why I use those concepts visually. So 800 to 1200. SVRI, which I don't think I have you. I don't know if it's on here. I don't think I do. But SVRI is the index, way more specific to that patient. So you might see that. If I don't ask for it, it's not going to be something I'm going to test you on. All right. So hi. Now you say to me, wait a minute, Lynn. Vasoconstriction. If I lose volume, if I'm bleeding in the parking lot and you don't find me, what does my body do to compensate? Heart rate goes up, right? Because it says, where's the blood? Where's the blood? Where's the blood? And it vasoconstricts. It's a compensatory for that volume loss initially. But if you leave me out in that parking lot and don't fix me, it eventually fixes. But you may see a high SVR on somebody who's acute hypovolemic. Does that make sense? So you may, in hypovolemic shock early on, if you leave them, it's eventually going to fail. It's a compensatory mechanism in hypovolemic shock. Vasoconstriction could be somebody who we just can't get that blood pressure down. We're going to reduce afterloads to our ACE inhibitors and preload if that's the initial cause. Knowing your CVP, knowing every single number helps them make a better decision on what they need to treat them. If it's a volume issue and an afterload issue, we could do both. Does that make sense? We can give a diuretic and we if it's both. Now, low SVR, which you'll see a lot in your COVID patients, in your septic patients, terrible blood pressures, lots of vasoconstrictors. Okay, and we'll talk about those as we go along. And how do I know if they need volume? What am I going to do? Yes, and if they're not volume responsive, we're going to go to those vasoconstriction meds. Does that make sense? Okay. All right, contractility, the stroke volume, which we talked about, stroke volume index more specific to the patient. This left ventricular stroke work index. really tells me how well that left ventricle is contracted. That's the best indicator of what's going on with that left ventricle. That's the major pumper of the heart, right? Gotta get it out of the heart for the rest of the life. Again, it's a calculation that the machine does. I don't have to calculate. Debbie Phillips can, but I can't. Continually measured. Now I have this. I don't know if it'll let me. Oh, can you see it? Okay. So remember I said there was a CVP port in this one, proximal injectate port. We take 10 mLs and we inject, and it goes past the temperature probe and says, this is different than the patient's core temperature. That's why we need the temperature. We're getting a cardiac output now. Measuring you injecting that. So let me do it again. Okay, so we inject 10 mLs, and again, room temperature versus body temperature. It goes past, see where she's injecting 10 mLs, and it gives us this waveform. And this magic number shows up and says, boop, 4 point whatever. That's your cardiac output. So that when people say I have to shoot, they're injecting 10 mLs and making that waveform. It has to be over 4 seconds, and you do an average of 3. So if I get, let me ask you this, if I get a 6.0, a 6.1, and a 12.3, what are we doing with the 12? We're tossing it, right? We're doing the 6.0 and the 6.1. So if we have a really weird one, if they're all pretty close, then we would average them all, right? But if we have one that's because I didn't know how to inject correctly, or did it too slow, whatever, and it's a weird number, it doesn't match up with the other two, we throw it out. Make sense? The cardiac output, once we do that, the machine gives me the cardiac index. I don't have to do anything. The machine calculates all these things. Does that make sense? Once it has the wedge and the cardiac output, it can do all these numbers. I don't have to do those formulas that I showed you guys. The machine does it. Okay. There's your left ventricular stroke work index, 50 to 62. Again, the machine does all this. I hit a button. Hit a button. Don't panic about memorizing the thing. Sensitive indicator of what the left ventricle, because we need to know that. Okay. And it really makes sense. What positive inotrope am I going to give? You guys like that good. What else? Jovitrax or Jovitrax. If I have excess, then I'm going to give. Oh, I better hurry. I got a meeting with the president. Okay, now let me finish this. I'm going to end your misery. Really look at trends. Let's say my CVP's been 4, 5, 6 all night. Okay. Let's say that you get a report, they say, oh, CVP's been around 46. And you go in and you see a CVP of 14. What are you doing? Say it again. Okay, we got to ensure that they're accurate, right?
Yeah.
Now, could you have given a lot of blood and made them go to fluid overload? Maybe. Start with troubleshooting first. Look at your patient. A lot of times when you guys walk into the room, you're starstruck with all these IVs that you forgot that there's a human attached over here. They're your best indicator of what's going on, okay? Because sometimes their numbers will look really bad and they look good. And sometimes their numbers look really good and they're really good. Do you see what I'm saying? So really, question abnormal read, troubleshoot, level, 0. Make sure. Compare with the patient's baseline. What did I tell you my blood pressure was this morning? Don't expect maybe 120 over 80. Do you guys see that? The textbook says that's my normal. So, and assess the patient, don't be fooled by normal values. Really important. They're most important. And what is the whole picture? Questions? deep, huh?
Yeah, it is.
I told you it was, but you know what? Once you get it, you're like, oh my God, this stuff is so cool. And I was telling them, you know, like when I would give a diuretic, somebody with a high CBP, I'd be like, I fixed them. I'm super nervous. And it was really the medication, but I felt like I made a difference because I could see the immediate reaction with the line. I could see it. I could see the blood pressure come down. I could see the heart rate go down, that kind of stuff. So, all right, it's your fault.
Don't forget to end your recording.
It's always my fault.
It's your fault. Oh, thank you. It's your fault. I did throw some candy. Stop recording.
Welcome back.